have a market system that has failed to serve us. And what do I mean when I say a market system that's not serving us? It's a broken market system. The African continent, we are about 11% of the global population. We account for about 25% of the global disease burden, but yet we are only 3% of the global pharmaceutical market. So, which basically tells us that need does not equal to demand. So in economics, we learned demand and supply tend to go together. Here we see a lot of demand with very limited supply for our health needs. And then you look at the COVID-19 pandemic, and for an already very vulnerable health system, we tend to import a lot of the health technologies in the health system, the health commodities, the health drugs, the vaccines, the equipment that we use, even the PPEs. And with COVID-19, all of a sudden, we were all of us in the same boat. Not only, Africa was not the only needy person contributing 25% of the global disease burden. We actually saw the infectious disease burden shift from us to the north. And the countries that typically supply us, the North America, Europe, the tiger economies in Asia, are now also grappling with a pandemic on their hands, and the global supply chains that we depend on were immediately cut. So we have almost what you could call a perfect storm. And it is within that context that we're asking the question, can social innovation be the cure for Africa's health system? And to help us to discuss this, it is my honor and privilege to welcome a very distinguished panel of experts from academia, from private sector, and the one thing that they all have in common is they are all STEM experts. We have scientists, we have engineers, and I'll start off by introducing Professor Marion Moutugi. Professor Motugi is a career researcher. She's a PhD geneticist and is currently the Vice Chancellor of Amref International University. Professor Motugi, if you could kindly wave to our audience. Thank you. Next, we have Dr. Teresa Kinyari. Dr. Teresa Kinyari is a physician. She's also a clinical epidemiologist. She has worked as a physician in the Ministry of Health, and currently is faculty at the University of Nairobi. And she's also the chair of the Public Health Society of Kenya. On top of that, she's a social entrepreneur in her own right. And it's definitely an honor and a privilege to have you with us, Dr. Kinyari. Please wave to the audience. Thank you. And we have Dr. Simon Manyara. Dr. Manyara tells me he doesn't want to be called a doctor because his background is as a pharmacist. However, his career has really been more as a social entrepreneur within the corporate sector. Dr. Manyara actually is the Sub-Saharan Africa lead for social entrepreneurship with Boehringer Ingelheim. It's one of the 20 largest pharmaceutical manufacturers globally from Germany. And he has a wealth of experience of serving this very underserved market. And so it's definitely a pleasure to have you here. Dr. Manyara, kindly wave to the audience. And last but not least, we move from the scientists, the doctors, to engineer Mzalema Mwanza. Engineer Mwanza is, first of all, a civil engineer. She has founded 2 companies, one in civil engineering and another one a social enterprise in maternal child health, known as the Safe Motherhood Alliance. She's quite a decorated social entrepreneur, an Ashoka Fellow, an Echo in Green Fellow, and how you move from civil engineering to maternal child health. It really just takes amazingly innovative minds to be able to do that. And it's definitely an honor to have you with us, Engineer Mwanza. Kindly wave to the audience. So, and I'm actually just asking each of them to wave because you will be able to hear from them in just a minute, so that they can actually introduce themselves, tell you a little bit about their journey as STEM experts, as social entrepreneurs. And I will start off by inviting Professor Moutugi. Kindly introduce yourself and give your opening remarks for the next 2 minutes.
Thank you very much.
Moutugi, over to you.
Thank you very much. My name is Marion Moutugi. I am a professor of medical genetics. I have been a research scientist for 30-some years. I have worked in research, I have worked in industry, and I've worked in academia. I'm currently the Vice Chancellor of AMREF International University, which is a premier Pan-African university wholly owned by AMREF Health Africa, specializing in the health sciences niche. Thank you very much.
Thank you, Professor Moutugi. And two things about Professor Moutugi: she actually did teach me. She is my professor. And so I'm very honored to be able to invite you to be a panelist. And she's actually a very decorated citizen. She bears the title Elder of Burning Spear. And I can tell you, it's not just anybody who gets that. Typically, I only see it with cabinet secretaries. So how we have Professor Moutugi bearing that title, I hope she will be able to share with us as we go on. Next, I want to invite Engineer Mwanza, Engineer Mzalema Mwanza from Zambia. Kindly introduce yourself and tell us about your organization and what you're doing.
Thank you so much, Robert. My name is Mzalema Mwanza, and I'm a social entrepreneur and a civil engineer from Zambia. Safe Motherhood Alliance is the organization I founded to advance safe births for pregnant women in low-income communities and in rural areas, ensuring that they have access to quality healthcare. And glad to be here and share my journey with everyone. Thank you.
Robert, I think you're on mute.
Thank you. Thanks so much. Yes, so thank you, Dr. Mwanza. And next I'll ask Dr. Teresa Kinyari to introduce herself.
Good afternoon. My name is Dr. Teresa Kinyari Mwendwa. I'm the chair for the Public Health Society of Kenya. The Public Health Society of Kenya was founded in 2012, and we bring together public health specialists working in academia, in the public sector, with development partners, and with international NGOs, and also in the private sector. So one of our thematic areas is to really look for solutions, innovative solutions for health systems. And wearing now my other hat as a lecturer in the Department of Medical Physiology, we came together with a team to work on a non-contact thermometer that we're using telemetry that I shall be able to present to you as part of the team. So I'm a clinical epidemiologist with more than 20 years experience in infectious disease, and I'm really glad to be part of this panel. Thank you.
Thank you so much. And last but not least, Dr. Simon Manyara. Karibu, please say hello.
Thanks, Robert. So I'm Simon Manyara. I'm a pharmacist by training. Although I've spent most of my working life solving problems around access to healthcare, so with a lot of expertise in global health and access, basically. I work with a company known as Boehringer Ingelheim. It's a pharmaceutical company. Currently, I have dual hats where I'm responsible for marketing some of our products, but I also lead our social enterprise program. So we have an accelerator program that we run in sub-Saharan Africa, and I've been leading the operations of it within the region. So that's a brief background about myself.
Thank you so much, Dr. And I will also kindly give the apologies on behalf of Dr. Elizabeth Wala, who was not able to join us due to some circumstances beyond her control. But she does send her apologies, and we will definitely miss to hear from her. Anybody who's met Dr. Wala, she's an amazing advocate for health innovation. And she's unfortunately just not able to join us from Aga Khan, the Aga Khan Foundation. That said, I will also introduce myself. My name is Dr. Robert Karanja. I'm a co-founder of Bilgrow Africa. We are an organization that provides business incubation and seed capital as an investor in early stage companies, startups that are working in the health and life sciences sector. We've operated in Kenya and East Africa for the last 15 years, supported roughly over 20 companies, and we've been able to see them being able to bring in more than $10 million worth of foreign direct investment into this region, into health innovation, and impacting more than 2 million lives through the power of social innovation and social entrepreneurship. And so with those few introductory remarks, I want to set the stage for for our discussion this evening or this afternoon by calling on Professor Marion Moutugi. You've had an amazing career in academia, in industry, but I want us to focus on academia first. And if you could just share with us what, in your opinion, is the role of academia in nurturing social entrepreneurship, and how can this actually, in extension, lead to or enable us to build a resilient health system in Kenya, in Africa, and really looking at sub-Saharan Africa. Professor Moutugi?
Thank you very much. Thank you very much, Robert. The role of academia, particularly universities, is threefold. It is training, research, and extension. Now, research is right in the middle because you train using information that has come about from research. Extension is the one that is not very well understood or well developed. And I believe that is where social entrepreneurship lies. Extension is actually the end of that spectrum. It is making sure that the research findings end up into a product, into policy change, or into practice. Now, many of us academicians, once we publish, we think we are through. Once we publish, we believe we've gotten our promotion, we've enhanced our CV, and we think we are through. But actually, you're not through with research until that the research findings reach the end user, where the end user may be the woman in the village who, like Muzalema will tell us, is in a challenge in terms of safe delivery. It is the policymaker who will influence policy. It is the legislator who will influence legislation. It is actually innovation and invention where you end up with a product. This is the weak link. And that is the role of universities. And that is why I believe social entrepreneurship has a place, because usually when we talk about innovation and inventions, we think about big industry who come up and buy off the researcher and buy off the idea and move on. And that is why the role of research universities is to train researchers on that extra step of moving research into, for example, a product. The issue of intellectual property, the issue of patenting, the issue of protecting and making sure that it is scaled while the researcher benefits. So we have not done very well, but this is the way we are going. And this is where social entrepreneurship comes in, because if these research ideas are quickly taken up by big industry, then big industry, their main focus is making money. And therefore, the ordinary citizen who requires this will not get it, because probably they will need time to recover their money in R&D, and therefore the rollout will not reach everybody. There is, of course, the role of governments, where governments are supposed to ensure that this reaches the citizens, but unfortunately, this does not happen. And this brings in the issue of ethics, because it is the role of government. Their very existence is to provide services to their citizens. And these services are in the area of health, in agriculture, in everything. But once these ideas are captured by industry, then there is a delay in rollout, scalability, and of course, sustainability. I do not know whether that helps, but I believe I got to a place in life, and I'll talk about that one later, where I'm not really happy to publish anymore. I had published enough. I had gotten my my promotions, but then I asked myself, all these publications lying in the shelves, they are quoted by other researchers, but does that information reach the end user? And that was a turning point in my life. And maybe I'll share about that a little more. Thank you very much.
Thank you. And I'll definitely come back to you for that, because that would be really great to hear from you, how you've actually taken up the challenge of translating research findings to impact. But you mentioned something about big companies and the question as to whether they can actually serve the citizens, especially in least developed countries like we have in sub-Saharan Africa. And we have with us Dr. Manyara, who is from Big Pharma. Is there any way that Big Pharma can actually serve our population? Is it purely just profit, or is there some mechanism, some middle ground somewhere where you can strike both the profit and the impact that Professor Moutugi would love to see?
Right, thanks for that, Robert. I think the topic is actually, it's not about profit or lack thereof. I think for me, it's about sustainability. And in my experience, I think that the way to achieve sustainability is twofold. One, you have to constantly keep innovating, because the problems in this market are very context specific. So you do not have plug and play solutions. If I came and brought the best vaccine for COVID, you might still find people, not benefiting from this vaccine, because you have to look at it holistically. In terms of supply chain and all these topics. So I think that one, there needs to be continued investment in innovation. But that said, it's also important, in my opinion, to realize that you need to have sustainable partnerships, because alone you cannot be able to go as far. So I think that the combination of these aspects, that you look for partnerships and you constantly drive innovation and create a culture of innovation within the system, then I think that can really help patients to be able to access medicine. And I have examples I can share about projects we've worked on with one of our partners, Ashoka, with Accelerator Program. And you come with a certain idea about an innovation that you want to work on. We want to say make sure that a certain clinic can care for patients with diabetes and hypertension. But you go in and you realize that that's not the only issue. You have awareness, right? So you have to tackle the awareness bit. Do you send community health workers into the villages or into remote areas to try and screen patients? Then there's the topic of affordability. How then do you optimize the supply chains, right? So that patients can actually be able to afford them. And then how do you then make the services available within these communities? And post that, how do you make patients then also continue or stay in care or retain them in care? So I think that, to kind of sharpen the message a bit better is we need to have innovations, we need to form the partnerships, and we need to think holistically about these problems that affect our markets. But there is a sweet spot where you can sustainably make the medicines and the services and the care available and affordable to patients.
Thank you. And I think as we go forward, we'll come back to you to actually get some precise examples of how you've been able to do this. I believe Boehringer has been around for a few decades on the continent. So I'm sure there must be some good examples that you can be able to share with us. But even as we talk about the role of academia, I also want to reach out to Dr. Kinyari, because she is also faculty at the University of Nairobi. How do you see your work as a researcher within the university environment, speaking to solving Africa's health systems challenges?
Thank you so much, Robert. I think in academia, we are really looking at solution-based research in terms of being able to, yes, we accept we live in resource-limited settings, but we have the answers to the solutions in our health systems because we know what can work and what cannot work. So for us, we are looking at research that is industry-driven, and we can only do that if we talk with industry to be able to find out what the gap is. And this is a good example. I shall discuss later how we came together during the COVID response in a multidisciplinary team to build up one of the solutions. So I believe we cannot be able to achieve anything in academia without talking to industry. The question must come from industry to the academia and then back to the industry. Because that's at the end of the day, like what Professor Moutugi said, it's all about getting your science back to the end user. If we can't get our science back to the end user or the primary beneficiary, then it doesn't matter how many papers we publish. It really won't make a difference. And again, even in terms of job creation, working with the industry then is able to help us look at job creation opportunities for our young people who have very brilliant ideas. Thank you.
Thank you so much, Dr. Kinyari. And I think we've listened to the perspective from academia, and I want to invite the engineer Mwanza. Does private sector innovate? And even before you go there, I still would really want to hear your story. How did you end up from civil engineering to social entrepreneur on maternal child health? And what has been your journey as an innovator from the private sector in terms of speaking to Africa's health needs? Engineer Mwanza.
Thank you so much, Robert. So, my journey begins as with any social entrepreneur. I think it seems we all have similar intertwined stories. Is when I looked at my own situation when, I was pregnant myself, and I realized the challenges that women faced accessing healthcare. So, I'm a civil engineer, have been for 15 plus years, over 10 years public sector, 5 years private sector, running my own firm. And then I found myself, pregnant, and realizing that, due to the broken healthcare system that we have in the country, women were being asked to bring their own birth materials. They're being asked to bring their own scalpel blade, their own delivery mask, their own their own gloves. And this got me thinking, after making 10, 15 stops to chemists, to pharmacies, and I couldn't find everything in one place. I realized that if I was having an issue and I'm in the capital city, what about in the rural areas? And the more I researched, the more I realized something had to be done. And the more I kept questioning people to say, doctors, who are colleagues of mine, to say, why is this happening? Even the Ministry of Health. And they would tell me that, in Africa, we have huge issues we're dealing with. We have HIV, we have tuberculosis, we have cholera. So, in terms of maternal health care, women will be, what we're asking them to bring their own birth materials is something minimal. But in fact, it's not, because they're not accessible. They're either too expensive or they're not in your location if you live in a rural area. And that is how we set on the journey of Safe Motherhood Alliance, really. And, looking at the philosophy of being an Ashoka Fellow, it says, every person is a change maker. And at that moment, I didn't think it was really possible to shift what was already existing, because something that was not normal had been made mainstream, and women are being asked to provide their own birth materials. And if they didn't have them, we had instances where women are being sent back, being made to wait, or looking at very, very difficult and dangerous alternatives of using traditional birth attendants to help them deliver in the communities. They were not trained, they're not skilled, they're not equipped, and they're literally using the sharpest tool in the kitchen to cut the umbilical cord, for example, not realizing that they're really introducing an infection at that point. And because I think this is something that, was a personal journey for me, which is why I'm so passionate about maternal health care, because I saw it firsthand, the challenges that women are facing. And really just sat down and, and thought about what can I do in my own space. And it really started off as a small project to just help myself ensure that I'm, when I'm in labor, I'm not faced with an odd question of what do I do? Do I access a health facility? If I don't have a scalpel blade, will I be sent back? And that has grown into what Safe Motherhood Alliance is. Really, it's a project that has grown with the support of government. We're working with Ministry of Health, working in 10 health centers in Zambia. And what we have is our flagship product is called a baby delivery kit. A baby delivery kit contains all the items that are needed for a safe birth, as recommended by WHO and Ministry of Health. So we're certified by Ministry of Health to be able to distribute this product. And because I'm a social entrepreneur, we're always looking at sustainability. We're always trying to ensure that we're around, in the next coming years. So this is really driven as a hybrid model. We don't donate the products that we have, but we retail them at a very minimal cost to our beneficiaries, because we know they need this product and they're willing to pay for it, but at a price that they can afford. So currently, we have distributed over 20,000 baby delivery kits to 20,000 pregnant women in Zambia alone, looking to, triple that number really next year. And despite the issues of COVID that we've had, which is what's put us together, we have seen, phenomenal changes in the work environment that we have, where, restrictions are placed on pregnant women to access health facilities. And because we've already been working in this space, this is where we're now able to hone our skills, ensuring that women have the right access to information, the right access to tools that they need. And something that we add to our business model as well is we work with traditional birth attendants. We train them on safe birth practices. We also equip them with baby delivery kits. So they essentially become our distribution agents, and they earn a commission off every kit that they sell. And this is where we're seeing the biggest driver of change in the rural areas and the low-income communities that we work in, seeing pregnant women demanding the right to healthcare, demanding access to hospitals, not before, where when they're chased, they don't have a choice because they tell them you don't have the materials. We can't help you here. There's nothing for you. And you're already in labor. What do you do in that situation? So we are ensuring that women have dignity, and we also ensure that they have access to the right materials and information as well. So that's my short journey, through Safe Motherhood Alliance, working with partners as well, ensuring that we're able to also deliver other products that we know are key and needed in the maternal healthcare space. Thank you.
Wow, thank you, and that's amazing. I don't know where are those emojis. So to look for the emoji for clapping. I can't find it, but a big thumbs up for all the amazing work you're doing in Zambia, for you and the team at the Safe Alliance. Sorry, why am I confusing your name? The Alliance, Safe Motherhood Alliance, and I think it's something that we really need to be able to dig a little bit deeper, because what you're talking about is really not as easy as you making it sound. You took a kit that was already in the market, I don't know for how much, but you're able to reduce the price, maintain the quality. What did it take to do that? If you could just share some of that.
So just to correct you slightly, Robert, there was no kit in existence when we started.
Okay.
You literally had to go find these items shop by shop, chemist by chemist. And there are 10 key items that are requested a woman to bring for her childbirth, given by each clinic or private public health facility. If you go to a private hospital, of course you'll be served and you have no issues, but you have to bring out your checkbook. Most women in the communities we work in can't afford it. So really it took innovation on our part, as well as looking critically at what were the issues that were disturbing the value chain. Why were women being forced to bring their own birth materials? And there were three main drivers that we found. It was the high cost, it was lack of access to the sterile supplies, and also lack of access to trained medical personnel. And this is what we're doing, is tackling these three systems, trying to create this triage of intervention in the maternal healthcare space. What we do as well is we realize most of the materials in the kit are imported. So we are trying to reduce the cost of the imported materials by manufacturing some of those items ourselves. And, being an engineer background, I'm always thinking, I'm always looking at how do I solve this issue? And one of the largest drivers of cost in our baby delivery kits was the sanitary pads. So when we looked at this, everything was imported. And we decided, what does it take to actually, manufacture this ourselves? It's not rocket science. But because the space of sanitary ware has not been innovated for the last 8 years, let alone in Africa or Zambia, everything is being imported from abroad. So we're currently manufacturing our own sanitary pads using local materials, using biodegradable banana fiber. So, for us, the banana tree is literally a miracle, tree for us, because we're using the fiber that has been thrown away in banana plantations, and that waste material, literally looking at re-engineering it to create a sterile product that we're able to serve and sell at a high quality, but at a very minimal cost to the beneficiaries, ensuring that that chain, the reproductive cycle, is not disturbed, that the mother is able to outlive the first 28 days post-birth, where we know that there are always complications for her. If you look at the stats globally, we have over 300,000 women and 2.7 million babies dying each year, not in Africa alone, but around the world, because of the complications I've mentioned. Inadequate healthcare systems, untrained medical personnel, women really posing dangerous situations on themselves just to ensure they have a healthy pregnancy. And this is what we're doing at Safe Birth Alliance, really trying to advance safe births in Zambia and Southern Africa.
Thank you so much. And I'm actually remembering in our earlier discussion, you did mention you do have a video that you can share with us.
Yes, if Patrick can share it.
Would this be an appropriate time to actually see some of this? Thank you.
It would. Thank you.
So let's see whether we can cue that, just to have it's really amazing to be able to see for yourself social entrepreneurship, social innovation in action, and being able to impact more than 20,000 lives. So if it's mother and child, that's already 40,000. Patrick,
that's correct.
Can you help us with the video, please? And maybe as he's doing that, you've also been able to, you talked about two things. So there's the local manufacturing, so that you're able to do the import substitution. There's actually bringing these kits together and being able to assemble them. And then the other thing that I think you mentioned, which I think it would be helpful to, the traditional birth attendants. And because you talked about the lack of clinical expertise. How have you been able to fall back on our traditional knowledge to be able to actually provide quality healthcare, and integrate it with the social innovation that you've been doing?
So, knowledge on childbirth with traditional birth attendants has been available to them for centuries, right? They are our birth mothers when there were no health systems available. So how do we connect the two? How do we bring the traditional and the Western medicine together to ensure that women's cultural, beliefs and traditions are also being respected? And this is what we try to do, is when we, identify a traditional birth attendant, we also train her on safe birth practices, and we connect her to the nearest health facility so that we have what we call an Uber for pregnant women. It's as easy as calling up an Uber to say I'm in need of help. There is no 911, there is no ambulance. How can you ensure that you have the right healthcare system in your home, in your small bedroom, and create the right environment to ensure that you have a healthy childbirth? And this is where traditional birth attendants play a very critical role. We work with the Ministry of Health to also train them, ensuring that they understand the protocols and the standards that are needed during at the point of childbirth, because we do know, post-birth, if care was not taken at the point of childbirth, an infection is introduced. Tetanus, women go through, PPH, not realizing that they're actually in shock. And, for no reason, she, passes on. And now the traditional birth attendants, because they have that knowledge and the skill, and as well as the kit, equipping them, they understand, the measures they have to take to ensure that the systems and the communities they work in are actually very safe for them. So definitely this, working with them as part of our systems change process, as an Ashoka Fellow, as an Equity and Green Fellow, has helped us shift that paradigm. And, just talking to social entrepreneurs, when we started in the space, there were no standards for maternal health care. So we do understand that, we had to create something that was not there, and which is why, we love these kind of programs for Ashoka Fellows to ensure that women, and even when we're working as social entrepreneurs and as an organization, we want to make sure that, we're self-sustainable, ensuring that we're connecting all the dots and collaborating with all, academia, researchers. Right now we're working on, 3D printed technology, ensuring that how do we manufacture items in the kit locally, 3D printed masks, and not relying on global supply chains, which has let us down during COVID-19.
Wow, and that's amazing. I'm glad to see, even within the COVID-19 global supply chain collapsing, again, the engineer that you are, you come up with more solutions, speaking to the COVID-19 situation, and really applaud that. And it really shows how private sector is able to rise to the occasion and to actually save the day as social entrepreneurs. And doing this through social innovation. And I think, I believe we may be having some technical challenges with the video. So, there we go. We'll pause for a couple minutes and just check in on the video to see what Mzalema has been telling us about. Go ahead.
My name is Muzalema Mwanza from Zambia, and I'm the founder of Safe Motherhood Alliance. We provide sterilized baby delivery kits to pregnant women in rural areas and low-income communities. I developed a kit when I was pregnant myself with my first child, and I was asked by the hospital to bring my own birth materials: gloves, scalpel blade, delivery mat, cotton wool, disinfectant. And I was shocked that I had to provide these things myself. And I really had a struggle to find everything in one place. And I felt, if I'm struggling, what are other women who are in worse situations going through? Which is what led me to come up with the delivery kit and pack everything in one kit as recommended by WHO. And we're working with the Ministry of Health in Zambia. The impact on the women has been phenomenal. We've been able to provide them with life-saving products. We're currently working in 6 clinics in Zambia. We have about 20 clinics that are on the line waiting to roll out our kits. We're looking to end the year having sold 10,000 kits this year.
We caught up with Muzalema in Zambia to find out what impact COVID-19 is having on their efforts.
We are deeply concerned. We have been monitoring the situation since we first heard about the pandemic in December 2019 and have been amazed at how it has traveled from its original state in China to globally around the world, and now it's in Africa. We are on lockdown. Nobody was prepared for it. WHO is trying their level best, and so is our local Ministry of Health, to be able to carry out testing and as well as advise the public on safety procedures. But we do know that women now, because a lot of people will be out of work, a lot of people have been sent home on forced leave, some paid, some unpaid. So we do know that the women in our target populations will be greatly affected. So there are a number of procedures that we are implementing as an organization to be able to counter this. We're looking at stocking up on key products. We're looking at key areas where we can partner with organizations to be able to make the kits available. This will have a huge impact on our finances. We're currently working in 10 health facilities in Zambia and to date have distributed 10,000 baby delivery kits. Currently, we're supplying between 50 to 100 kits per week. We have seen that number drop drastically, but the demand for the kits is still on the increase. So we're trying to still figure out how do we make sure that women have access to the essential products that they need so they can protect their child and themselves at the same time.
Wow, thank you. And again, if we were in the same room, it would be applause, applause, applause. Kudos for an amazing job that you're doing. And
Thank you.
we're excited to see our engineers stepping up, putting together the kits, doing local manufacturing of the sanitary pads, of the PPEs, and actually being able to ensure that we don't just hold our hands up in the air and give up. And I think you also mentioned something about you called it a magic plant, the banana, and it's we have Professor Moutugi with us, who I think has been able to interact with this magic plant quite a bit in her long career, in her long distinguished career as a geneticist. And Prof, I just want to call on you so that you can just kindly share with us what have you been doing with this magic plant here in Kenya, and especially as an innovator, as a social innovator, as a social entrepreneur, and how have you been actually using a humble plant like the banana to speak to our public health agenda?
Thank you very much. I will ask the person out there to just put up what I sent. I just want to describe that extra step of moving from research to the end user. So I want to discuss, if you can just put it up, I'll be happy. It's just not a PowerPoint, it's just a clip. Right, this is work that was done. We worked in one area of Kenya where we noted that the agricultural, is it coming on?
Patrick, can you share with us the clip for Prof? And maybe you can just go ahead, and then once it's ready, we'll be able to
where it's an agricultural part where the people there depend on agriculture for their livelihoods, but agriculture had lost its the income. It wasn't as productive, and therefore poverty had started creeping in. And at that time, the university I worked in had developed tissue culture cultivars, pest-resistant cultivars of bananas. And this was the science bit. And with that, we were able to develop a model And I have described it. It's described in this book out here, Gender Inequalities in Kenya, where we took we leveraged on something that was pre-existing, where self-help groups are popular, and they are usually women groups, and they are usually table banking and merry-go-round and that kind of thing. And so we did have a community-based organization which had corporate membership, and we had over 100 self-help groups as corporate members. And through their pre-existing systems and operations, they have chairmen, they have secretaries, they have treasurers. We introduced banana farming as a lucrative and alternative crop that would particularly help the household, because we believe that when a woman has resources, she will most probably use them in the household. And therefore, the banana plant is viewed as a female crop. So mama in the village will have no problem gifting you a banana bunch, but she will have a problem giving you coffee or tea, because those are male crops. And yet, both the women also work in husbandry for the tea and the coffee. But the banana is viewed as a female crop, a woman's crop. And therefore, we were able to assist them with their own resources, from their self-help groups, to plant those bananas and cultivate them and put them into groups where they could sell them. Now, it is interesting because that area in Kenya now, if you go to that area, it has the largest banana market in the whole country, I dare say in the whole region, because it was taken up. A banana was a crop that was seen as a subsistence crop, not a cash crop. But now with this kind of thing, it was seen as an alternative to the cash crops that were not productive, were not as lucrative as they were seen. But even more so, the most important thing I want to highlight here is the use of pre-existing institutions, because the self-help groups that we were working with were already there. We vetted them for good governance. We vetted them for good procedures, so that we leveraged on already pre-existing bodies. The other project that we had was on HIV and AIDS.
Maybe before you get to the HIV and AIDS, Prof, I'm very curious. How did you make this initiative to be sustainable? And I think we heard from Simon. He said, yes, we can be able to have impact, but how do we make it sustainable?
Sustainability was easy, because once a person had a cultivar, and because we use pre-existing organizations of self-help groups go on and on and on, especially when they are stable and they have been operational for many areas. And so sustainability was just an issue that was dealt with at the self-help group. So we were not coming in new. We were using a pre-existing structure. We were introducing them an extra program, because many of them were merry-go-rounds. It was contributing for funerals. It was contributing for weddings, for babies. So we just gave them one extra product.
Excellent. And you are now talking about how this then ended up having a ripple effect into even HIV. Professor Moutugi, I think you're on mute. Something may have happened.
Thank you very much. We then introduced, that was the time that HIV was a big issue. This was a time that HIV was a big story, and we were concerned. We were concerned that HIV was not, the information about HIV was not reaching the women, the females, the women. And it was shrouded in mystery. There was a lot of stigma around it, because it was viewed to be really associated with immorality and so forth. And so we brought in the issue of prevention of mother-to-child transmission. Now, when a young mother, at that time, the protocol said that a mother who was HIV positive should not breastfeed. And so the fact that a young woman was not breastfeeding was a disclosure that she was HIV positive. And that came with stigma and so forth. And so she would breastfeed and risk her unborn child. So we came up with an innovation where in that community, the naming of children is, children are named after their parents. And so they are, for example, the baby would be named after the paternal grandmother or the paternal grandfather. And because they were living all together, it brought in some degree of conflict when the baby was not breastfed. And so we started targeting the older women and the older men who were the mother-in-laws and the father-in-laws of this young woman. And we exposed to them the issue of HIV and the issue that actually didn't really matter if the daughter-in-law was positive. It didn't really matter where it came from. It just meant that the infection was in their home, in their son's home. And now what was threatened now was the fact that this a baby who was going to be born and be named after this woman or this man would not survive. And to make that baby survive, it is good that that baby is not breastfed. And so we actually included them as mobilizers. We call them mobilizers, where they would go out and look for their daughters-in-laws and take them to the antenatal clinics, and they would also take their sons. So we organized with the antenatal clinics that if a couple came to the antenatal clinic, they wouldn't queue. They would go ahead of the queue. They would be served. They would do their couple testing, counseling, and testing, and they would be put on the program if they are positive. But it was the mobilizers who are the older women, where the culture of naming the children, the babies. So it was like, I want to survive, the baby named after me to survive. And therefore, for that baby to survive, the mother cannot breastfeed because I know the mother is positive. So again, we use pre-existing structures,
yep,
the culture, and the right demographic group so that there was a buy-in. Thank you very much.
Thank you so much, Professor Moutugi. And this is really amazing because it's something that we started hearing with Mzalema about leveraging culture, customs in her social innovation, the traditional birth attendants, their acceptance by the community, and helping them to be able to meet and serve the community with these modern tools. And here you are talking about how you again leveraged culture and the traditional norms in your innovation to be able to intervene in the mother-to-child transmission of HIV. And you know, as we talk of HIV, it makes me really think, and I just want to kind of throw this to Simon. What are the learnings that we can actually pick up from the HIV pandemic, even as we look at the current COVID-19 pandemic? And in particular, my main concern is we literally saw a 10-year gap between the global north, where, in terms of when ARVs became widely available, and you know, it took a whole decade for ARVs to become available here in Africa, with a lot of deaths occurring as a result. Now, as we look at the COVID-19 scenario, are we going to be having a repeat of this? And how our big pharma and especially the social enterprise angle of it like what you're doing here in sub-Saharan Africa, responding to the COVID-19 differently?
Right. So that's a loaded question. I think what worked with HIV was an integrated approach to care, right? So from my experience working in the HIV space, we saw a lot of people coming together. We saw the NGOs, the civil rights group, the pharma manufacturers with technology transfer. So it was an integrated approach, and even at policy level, that actually helped to transfer all these benefits, to the ground. And that's why I think it's really interesting that nowadays HIV is better managed in a lot of smaller facilities than your typical hypertension or diabetes or other diseases that might not even have as many, when well managed, don't carry as much complications, right? So I think that's something to learn, right? So, and I personally believe strongly in an ecosystem approach, and this is an integrated approach where I feel that if all the players come together and work together towards addressing, a common issue, then we can be able to move forward. I think it has to also start with policy to make sure that we have the right frameworks in place that allow different players and stakeholders to come and talk to each other. From there, you need to have the right infrastructure, because as much as I mentioned before, it's not plug and play. You can get the best vaccine, but if you don't have cold chain, then it's as good as not helpful to anyone. So we also need to address the supply chain part of things. We need to do technology transfer or even education of care providers. How do you administer the vaccine? How do you treat? How do you operate in a sterile environment? So I think that we can be able to achieve. Because we've learned a lot from HIV. I think that we can fast track and use these learnings to achieve outcomes faster. And I think the fact that it's also a global pandemic helps to make the urgency a little bit, it's urgent for everyone, and it's on everyone's radar. So I feel that we will be able to get the vaccine in time, but the infrastructure also has to be in place as well. And we need to have political goodwill from the right players.
I'm glad you talked of infrastructure, because we have Mzalema with us. So it looks like we need more engineers in this space of health. And we may need to be able to start thinking, how do we clone Engineer Mwanza? But as we, just to change gears a little bit, I want to direct this question to Dr. Teresa. Do we have scope in Africa for the biomedical innovation, and how have you been able to, as an innovator, as a scientist, how do you, and as a social entrepreneur, how have you been able to respond to the COVID-19 through social innovation here in Kenya? You're on mute. There you go. Thank you.
Thank you very much, Robert. I think you're very right. We have an opportunity, and all the opportunities to be able to nurture health innovations or any other innovations in Africa, even in a South-to-South collaboration. I think the only problem is that we tend to work in silos. I'm doing my thing, maybe Professor is doing her thing, Mwanza is doing her thing. So at the end of the day, we don't talk to each other. We have a common problem. So what COVID-19 did was to put our heads together, to force us to put our heads together, to come up with one of the solutions for the pandemic. And this is not just one of the innovations we've come up with. Previously, I've worked on several other innovations but have not reached this level. And my colleagues also have done the same. But from our experience with the COVID response, we have a lot of capacity. And all we need is horizontal consulting and cross-pollination of ideas to be able to come up with solutions for our country. we normally say we are in a resource limited setting, but at the same time, we know how to deal with limitations and how best to work about it. So one good example that we have is the Mensa fever telemetry that we came up with. And this was because during the pandemic, we had a big issue about being able to know about the symptoms, and fever was one of them.
That you have lined up for us?
Yes, yes.
So, I'll just request the technical team to kindly cue it for us as you continue.
Yeah.
And once it's ready, we'll just take a pause.
Okay.
Please go ahead.
So fever is one of the main signs and symptoms of COVID disease, and this is what was the motivation for this particular innovation. So maybe we can.
Maybe just go ahead and play it, and then we'll continue.
So the main thing was because sometimes you get a thermal gun and it. Yes.
I'm sorry, I'm on mute all the time. Can we play the video, and then just so that we can be able to now follow the discussion? I think it would be good to have it at this point. Patrick? Looks like we are having some technical challenges. Sorry. So let's just go ahead, and then once it's ready, we'll allow the technical team to intercept us.
Okay, so as I'm also a medical physiologist. I teach medical physiology at the University of Nairobi, and every time you went to either a supermarket or in any other place, someone pointed a thermal gun at you. I don't know how many of us get to see what the reading is. Sometimes you get 33 degrees, which is not biologically plausible. Sometimes you get 45 degrees, and yet it's not the temperature. So there's a lot of variation because of the environment and also because of the particular device. And so we don't have consistency in the body temperature that is actually measured. So my idea now as a medical physiologist was to come up with a skin to core conversion component of the thermal gun, which would be very important to be able to work with. So this particular component helps develop an algorithm that will be able to pick up whatever environmental temperature that has been picked by the thermal gun is converted to a core temperature. And what is core temperature? Core temperature is that body temperature that you have that does not change based on the environment. And this is the more reliable temperature of how your body is. And when you get an infection, after about 3 days, your body will respond and you're going to get temperature. So temperature can come from within as a result of a change, even resulting to hormonal changes in the body, but can also come as a result of a disease. So in this case, with COVID-19. So that additional component where with this particular device, we'll be able now to do a skin to core conversion, then that puts it ahead, makes it different from the other thermal guns. So that whatever reading that you get then will be the actual core temperature reading that you'll be required to. So this particular is still under development, but this particular component is what we'll be working on. So I made contact with a colleague who is an electrical engineer, Peter Akech, who is with Mensa and Analytics, and apparently he also had the same idea, looking at temperature and fever, and he's actually come up with a device that can be used to be able to identify non-contact temperature, but looking at it from a community-based point of view, mainly because with COVID disease, a lot of people have feared to go to the health facility. So our health-seeking behavior has gone down. And more importantly, because we've asked people to stay at home, especially the older persons. And we also know that older persons, because of the effect of derangements in their hypothalamic temperature control, they don't have the actual sharp changes in the body temperature. So you can easily miss fever in an older person as opposed to a younger person. So the idea with this device was to actually come up with a non-contact thermometer that can be placed in the community. We have a Nyumba Kumi setup. So it can actually be placed in the community where people can just pass by and take their temperatures the way we do in a supermarket, but then we'll be able now to monitor a fever. And this is now linked with what Willie Simons and his team using GIS mapping would also be able to do, to be able to come up with heat maps that will be able to identify the places where we actually have more fever, because we really have not been able to achieve testing for COVID disease, and we probably will never be able to achieve testing. So syndromic management becomes the key. And the idea of syndromic management was also floated in the Public Health Society by our colleagues. So this again was a key motivator to come up with this device. So basically, how does it work? So the way it works is that once you have the device, then you get, maybe then he can play the video. Then we can continue.
Hi, my name is Peter from Mensa Analytics, and I'd like to talk a little bit about our product, the Mensa Telemetric Fever Detector. A little background. As of 16th of May, Kenya has tested 39,018 people for COVID-19, and so far around 800 have been found to be positive. When you take the 39,000 against a population of 52 million, it means that at the test rate that we have, it will take the government about 216 years to test everyone in the country. This is the same problem that is faced across Africa with a shortage of test kits and no data in terms of the spread of the virus, because the fever detectors that are deployed in Kenya and across the continent do not have any capability to transmit the data that they are reading to any central server to allow epidemiologists, data scientists, and public health officials to be able to predict the spread and optimize the distribution of these test kits. So we came up with the Mensa Telemetric Fever Detector to address this problem. Currently, our primary target market is basically Kenya, the national government, the county governments, factories, and humanitarian organizations. Our business model is basically selling the hardware, leasing of our data analysis platform, and licensing the resources. We are looking at 12.5 million to help us be able to run the business successfully. And looking at our competition, they do not have much against us. Current thermoguns in the market sometimes produce unrealistic temperatures, but with this device, the temperature readings will be core temperatures generated through an inbuilt skin to core temperature algorithm. This will provide more accurate readings and avoid the temperatures that might indicate hypothermia. Our team is most qualified to implement this system, and we believe with the right resources, we'll be able to get our system out in the market within the next 6 months. Thank you.
Excellent. That's a great innovation, and I think just because of time, I'll probably try and because we need to open up the floor for Q&A. I think it's really amazing. Through the discussions, I think I've seen us talk about the local manufacturing, but substitution, and you're bringing this back again, that we are importing all of these technologies. We can actually create them, we can manufacture them, we can actually improve on them, and actually have medical health technologies that are world-class, that are actually homegrown. And this is an aspect of you as a physiologist being able to bring that expertise, combining it with engineering, again, back to Mzalema, fourth industrial revolution, the machine learning. I don't know that you're also using 3D printing, but I can see there's lots of rich, interesting aspects of innovation within that particular product. And it's a very timely innovation even for this time. With that, I think I want us to open up the floor just to welcome a few questions for any of the panelists. I believe Professor Marion may be leaving sooner rather than later, so I'll request if maybe you can start off with any quick questions for Professor Marion Moutugi, and if not, just any of the panelists. The technical team just advised me whether you can allow people to unmute or whether we can work with the questions from the chat. In the meantime, I'll recommend the chat as we wait on the technical team to help us with the muting and unmuting. Any questions? I have one of my own as we wait, because I think I kind of have this interest in all of the things that we've been talking about. And there's this amazing theme that has been emerging, listening to Professor Motugi, listening to you, Dr. Kinyari, Engineer Mwanza, and Dr. Manyara. First of all, this is one of the few panels that I've been involved in where I actually see more women than men in STEM, in innovation, as social entrepreneurs, and the perspectives that you're bringing are just simply amazing. How you've been able to leverage, especially the cultural aspect, and being able to look at what women have been doing all this time, and using that as an entry point, using it to speak to the sustainability of the social innovations that you're bringing to the marketplace. Can you just briefly, what has that journey been like for you as women, as women in social entrepreneurship? What do you? How could you say? Is it as easy? Is that why we have more women today than normal, or just curious? But I can see one quick question from Henrico Kondo. Does Safe Motherhood Alliance intend to upscale to other countries? I am working in Niger, and that kit would be very useful. Do you have any plans of going to Niger?
Thank you for that question. Definitely, we do have plans to scale up our project into other areas. We've had queries from as far as Venezuela, asking us about our programs, about how to get kits there, asking about our, for the blueprint of how we conduct our training programs, integrating birth attendants who are in the communities into, the health system, so that, as Dr. Kinyari said, people are not working in silos. So definitely looking at scaling up into other countries, currently in the next 2 years.
Wow, awesome. So please keep an eye, and I think if you don't mind, then I'll kindly request you and actually all the panelists kindly share whether it is the URL for your organization or your email, so that when you have that kind of interest, we're able to direct it to the right persons or the channels that you've set up, so that there's that opportunity. Yes, so we're talking about women in social innovation. What is the journey like?
I think for me, it started, it didn't just start with Mensa, the telemetry. It started even as a medical doctor, working even as a medical student. I think of myself as being lucky because I've had an education, but I think when I think of my colleague, the woman in the village, who will definitely know when a child has fever, just because she'll feel it on the forehead, and just basically know when her child is not feeling well. But I just thought but still find she may not have the resources, she may not have the support that she needs to take the child to hospital. So I think of a woman like that helplessly watching her child die at home, maybe because of respiratory distress, because of malaria, because I've done a lot of work in malaria in the community, or just not being able to access the services. So I feel it's better if I could get a way of getting the solution closer to her doorstep, then that would actually be the best, because that will lead to secondary prevention, which is the early detection of disease. And that again ensures that a lot of lives are saved. And also, more importantly, because women are sort of disadvantaged in terms of being the primary caregivers. They have to stop their normal daily activities to be the primary caregiver. So my question has always been, how can we add value to what a woman is doing as a caregiver? For example, for an older person with dementia, or someone else who needs some long-term care. So looking at it, I feel women, and especially looking at even what Professor Moutugi has talked about, the self-help groups, there's a lot that women can be able to plug in, even in terms of boosting their finances if they had the solutions in place. So I feel there's a lot we can do for each other as women.
Thank you so much, Dr. Teresa. And I can say one other question. It is excellent to have women like Professor Motugi and Dr. Teresa in STEM and social innovation. How is she mentoring young women in Kenya and advocating for more funding in medical research for women because their experience as caregivers is so important. And maybe even just to ride on that, I think in Africa, it's the only region globally where we have more women entrepreneurs than men. And in as much as that is the status, we find that it is actually harder for women entrepreneurs to access financing, to access the support that investors or social enterprise enabler organizations provide for entrepreneurs. How can we really embrace women entrepreneurs? How can we help them to scale even further? How can we? I love this aspect of being invited to go to Venezuela, Tunisia, to all over the place. And I think there's lots of opportunity that can be able to discuss. But I am reminded that we are running out of time, and so I'll kindly continue to request that the organizers will share the details of our distinguished panelists so that we can be able to continue having this discussion. I think when we started off, we were asking a very simple question. Is social innovation the answer to Africa's health challenges? And listening to our panelists, listening to Dr. Manyara and the work that he's doing in East Africa, in West Africa, listening to Mzalema and the work he's doing in Zambia, listening to Dr. Teresa and Professor Motugi here in Kenya, it's clear that there's a lot. There's a lot that social innovation can contribute to our health system. But I also get the feeling that we are barely scratching the surface, that we can actually do more. And I think we need to have these kind of conversations to keep elevating the opportunity that already exists. Being able to leverage our existing infrastructure, our existing systems, our culture, and all of these things that we already, the low-hanging fruits, and being able to ensure that they can yield the public health impact that we so desire and we're in such a great need of, even during this time of COVID-19. So I will thank each of our panelists. Thank you so much for being able to join us, for being able to join us and being able to share of your journeys of the sorry, amazing work that you're doing in public health, in addressing the COVID-19 pandemic, and in being able to do so across the spectrum, from academia to private sector to corporate big pharma. We are seeing amazing initiatives and amazing work on the ground, and obviously touching and impacting many lives. So with those few remarks, I want to thank also our attendants for joining this session and welcoming you to continue to be part of this conference. Today is just day one of amazing conversations about what the annual African Conference on Social Entrepreneurship is doing, which is really to highlight social entrepreneurs like we have on our panel today, and being able to learn how can we be part of the solution as opposed to being part of the problem, or probably just assuming that the solution is going to come from out there. How can we build on what we have and make it count and even take it out as we've been challenged by Mzalema. So thank you, everybody. And with those few remarks, I bid you a good evening and look forward to seeing you in the other forums that are going on in the conference As we say in Kenya, asanteni sana. Thank you and God bless you.